Hi. Okay, so this is my first meeting. I'm really excited about it. Don't really know what I'm doing though. You would think after watching everybody all these years, I'd have it down pat, but so I'm gonna cheat and read my notes here. We called the meeting to order, and so welcome everybody. Thank y'all for coming. I'm excited to serve y'all this year. And please silence your cell phones if you have not already done it. And I'm gonna call up the Rotarian of the day, which is Jennifer Pollard.
And we didn't plan it. It just literally just worked out that way. So, all right, if you would please bow your heads. So Lord, thank you so much for this amazing day and this amazing crowd of people that we are blessed to be here together with. Please bless this food to the nourishment of our bodies and us to your service. In your name we pray, amen.
Man,
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. And the four-way test of the things we think, say, and do. First, second, third, fourth, and fifth. Amen.
all right. So as you sit down, remember the cart buckets. I'm gonna try to speak really loud so everybody can hear me. So if it feels like I'm yelling, I probably am, but but remember the cart buckets. I have a goal this year to hit our numbers for the cart buckets. It ends up being $25 per person. So if you want to go ahead, knock it out, throw $25 in the bucket. We are going to get a QR code because you can donate online to the cart fund. So that'll be coming soon. Remember the cart buckets for Alzheimer's, and I know my life's been touched by Alzheimer's and dementia through several family members, and probably yours has too. So remember the cart buckets. Now, Greg Blakely, he is in a different role this week because we have an all new board. So Greg is our sergeant at arms, but he does such a good job announcing the guests and doing the raffle. We asked him to please continue that as sergeant at arms.
Y'all thought you were rid of me. The joke is on you. Okay, first of all, we have some guests. Paul, you want to introduce the three ladies who came with you? Sure. Brandy Upshaw with our marketing team, Brandy Talton, and Christy, who is Dr. Seth Ryan's office manager. Very good, thank you. And we want to welcome back her to Scott, who's at the Jessup Club and is going to join our club. Okay, Tamara, because you have such an honest face. All right, the winning ticket ends at 940.
Not me.
All right, you're eliminating Darren, who's got 940. All right, Jeff, come on up. Looking for the Queen of Hearts. Queen of Hearts, Queen of Hearts, we got the 8 of Hearts. You were close. There you go. Thank you.
You're welcome. Okay, and William, if he were here, we would ask him if there's any prayer requests. He's not. So are there any prayer requests? No? Yeah.
I want to make mention, Bobby Martin, partner of Tracy, her mother passed away.
Okay, thank you. Okay, community announcements.
We have one. July the 17th will be the last day of the Baldwin High School food drive. Apologies, last week I've been out of the loop. I didn't send a reminder out off my phone. Had a death and a wedding in the same family, so I've been going through a lot. But on the 17th, I will send out a reminder if you signed up for that. That would be the last one. So congratulations. details, I had an opportunity to be the Rotarian in Ohio. And I was actually able to talk to him about it. So great story to tell. And just look forward to email coming out.
Tell them how many meals we'll distribute after next week.
So 6 times 1,500, anybody good mathematician? So I'm getting at 6,000. 9,000. Okay, so 9,000 meals. Was it 15?
No, it's 15,000 a week.
15,000. So you're looking at about 150,000 meals. So who knows? That's a great number, 150,000 meals in the summer. Okay, so that's a great number, great story to tell. A lot of participation from the club, so good deal.
Yes.
Yeah, announcement on the back to school, thank you, Trey. Back to school bash will be on July the 21st. We'll be supporting that event. The club has made a donation to that event. They'll be sponsoring it through a donation. There'll be a bounce house out there for the kids. They'll be doing haircuts. If you need to be offering haircuts. We will have a tent set up out there. Right now I'm working with DMC, going to help provide the tents and tables for that. What we're going to do is we're going to have some pencils that we're going to hand out. But if you can come out and join that, we're really sort of planning by ear of what we will be doing. But someone said it, there'll be something someone needs help with at that event. There'll be volunteer opportunities, even if we have to get on the ground to find those. But it'll be a good time. We have pencils. Wear your t-shirt. It'll be a good time to celebrate the kids going back to school. But again, the bounce house, I think the donation that we contributed will be kind of sort of financing that. So good event. I can see us sort of, just standing at the bounce house, monitoring the kids coming out, making sure they get out safe, because those bounce houses sometimes you got need a little something coming in and out. Whatever we can do to assist on the ground for that event, it'll be a great event. August is maternity month, and we have a speaker coming in for that, and we're trying to find an opportunity to actively engage in some service when it comes to that project. But all that's coming together. This week we submitted our
District grant for Jill's books.
District grant. I really appreciate, shout out kudos to Bill. I really appreciate you taking me through that. You're the man, you know how much I appreciate you. So I appreciate that. But that's been submitted, signed, and we're just waiting for approval at the district level. But it'll be for Jill's books. And as you're aware, we can't spend anything until we get the approval. So once we get the approval, we can start working on that.
Okay.
Anything else I'm missing?
No, I think you got it covered.
Thank
Yeah.
you.
A couple of more club business. John Jackson, I don't know if you saw the news, but John has been inducted as the president-elect of the Georgia School Board Association. So congratulate John. And Dr. Price has been appointed to the Georgia Council on Literacy. And so there's been a day named in her honor. June 2nd is going to be the Dr. Price Day. If you missed the 85th celebration, you missed a really great event, but we recorded it. So it is online. You can go to our Facebook page or YouTube page and you can view that. If you couldn't hear quite what everybody said, the sound is excellent on that video. So you can go back and watch that. So that's available to you. And for a little bit more club business, we focused on the 85th celebration. We did not give our club awards for the end of the year. So now I'm gonna call Jennifer Pollard up so she can give her awards to her previous board.
So I actually have gone around and given my board members a little gift from me. Greg, can you hold yours up for me, please? So this was a little something I did that I heard about at a Rotary training. Apparently, they used to give these books to any new incoming Rotarian, and the name of the book is Adventures in Service. And Greg's is already signed from what year?
1968.
So they all have one of these books, or they have a book about 7 paths to peace, or one called Service is My Business. I have some extra copies of some of these books because I didn't know how many I was going to be able to get, so I bought as many as I could find. I have some extras back at the desk at my spot there if anyone would like one. But my year would not have been successful. I could have done nothing without the support of my board. Thank you from the bottom of my heart to all of my board members. Thank you. And we cannot close out a Rotary year without recognizing our Rotarian of the Year. And because he's been wearing a lot of hats today and been doing a little bit of everything, we're going to let him keep doing a little bit of everything. Greg Blakely, come get your award. There you go, sir.
Thank you. Thanks to all of you.
And we are also recognizing our Rookie of the Year, and I'm sure this will not come as a surprise to anyone. It was a unanimous vote by the board. Our Rookie of the Year is Tamara Saragusa. There's yours and a little. All right, thank you all. They always said past president is the best role to have in Rotary, and now I get it.
All right, well, congratulations to Greg and to Tamara. So now I think that concludes our club business. So let me pull up this PowerPoint and I'm gonna invite Paul Barkley up to introduce our guest today.
Good afternoon, everybody. I'm privileged to be here today to invite Dr. Seth Ryan here from Atrium Health Absent Baldwin to present on the fine work that he does at our facility. Dr. Ryan has been here in Milledgeville since at least 2005 and was a surgeon here under Oconee Regional Medical Center, and now is under our employee as one of our hospital-based surgeons. He is married to his wife Barbara, has 2 sons, Matthew and Travis. Tyler. I know I was gonna mess something up. But anyways, it has been a vital part of this community for a number of years and continues to be so, and enjoying the lake and the pool activities. So with that, I'd like to introduce Dr. Ryan to come and give a presentation to you.
And I'm failing miserably at the technology. So
Doing better than I would, that's for sure.
I'll let Eric pull that back up.
That's right.
I think I did turn on there.
Is it still up there? Yeah, okay, it's up there. Can we advance from that? Yeah, sure. Okay, let me just. Here we go. Is that right? Yeah. Perfect. Hey, everybody, it's nice to be here. Glad to join you guys for a nice lunch. Appreciate you having me. A lot of you know me, like I've been here for seemingly a long time. Most of my life, it seems like I've been here. I'm originally from up in Ohio. I came down and did my training for general surgery in Atlanta, and shortly thereafter moved to Milledgeville. I was in private practice here for about 13 years, and then when Oconee Regional was actually sold to Navicent, took a position with with Navicent at the time that then ultimately became Atrium Health Navicent Baldwin. We don't like saying that name very much because there's too many words in it, but that's the name of the facility now.
Just so you guys know, the C stands for Christopher. My mom liked the way that Christopher Seth sounded better than Seth Christopher. But I've always gone by Seth. If you call me Christopher, I will not answer. And in terms of the initials, a lot of people don't know what FACS stands for. That stands for Fellow of the American College of Surgeons. Once you get done with your residency and training, you take boards, and if you pass your board, you get that title. So I'm here to talk a little bit about what I do, what our hospital does from a general surgery standpoint. The first slide basically goes over my education. College, I did 4 years at Miami University in Ohio. That's where I met my wife. We are what they call a Miami merger. And ultimately what that means is that every Valentine's Day, we get a Valentine's Day card from them. But we've been together for almost over 25 years now. And she kind of stuck it out with me through all the education that you see here. 4 years of medical school at Ohio State. I am a Buckeye. Like I said, I was born and raised in Ohio, and still support them fully. As you can see, my little tag here has an Ohio State Buckeye thing on it. After medical school, I came down to Atlanta and did my first year of internship at what was Georgia Baptist. That hospital was bought by, I think, Tenet following that, and then ultimately Wellstar. And that's where I finished my residency. So 5 years of residency at Atlanta Medical Center in Atlanta. And then obviously since that time in 2003, I've been a board certified practicing general surgeon. So the next several slides basically go through kind of the systems that I deal with and what I do on a day-to-day basis. So from a general surgery standpoint, the first thing I sort of brought up was skin and soft tissue. And that can vary from anything into evaluating rashes, evaluating lumps and bumps that patients have, things like lipomas, sebaceous cysts. A lot of times we'll end up resecting those in the office. And then it can get to something a lot more serious like skin cancers, basal cell carcinomas, squamous cell carcinomas, and even melanoma. Those are pretty common down in the South. And so we see a fair number of those. They're all secondary to sun exposure, especially melanoma. And that's something that we do both potentially in the office, but a lot of times end up taking those patients to the operating room as well. Sorry, I'm having a hard time seeing this. Oh, the last thing under skin and soft tissue is wounds. Probably 10 years ago now, we used to have a wound care center in Milledgeville that was owned and operated by the old hospital system. That ultimately failed, I think, secondary to the fact that number one, patient population, we weren't getting enough patients there. And then number two, a great deal of the revenue from that facility was built upon hyperbaric oxygen therapy. And although we had that, we didn't have near the number of patients for that system that we need to have to keep the system going. So that ultimately closed. We still do some wound care. Wound care is a tricky beast. It's labor intensive, requires lots of nursing staff, lots of measurements and things that need to be done. You have to see the patients almost weekly. And quite honestly, we don't at this point have the resources or the population to offer full-time wound care therapy here. I still do some diabetic foot ulcers, especially. I'll see those patients in the hospital. If they require debridement, we can certainly remove dead or necrotic tissue from those. But a lot of the long-term wound care, difficult to heal wound care therapy, we'll send down to Macon. Breast care. I do a lot of breast care. It's amazing how many patients I get referred to me with abnormal mammograms. So the first step, obviously, that I handle in terms of breast care is evaluating the mammogram. What's abnormal about it? What needs to be done? And then ultimately, if a biopsy is warranted, we'll go ahead and do the biopsy. Depending on whether or not we can feel a breast mass or see it on ultrasound, I can certainly do ultrasound guided biopsies in the office. If it's a palpable mass, we can do a biopsy in the office. If that ultimately turns out to become a malignancy, then we'll schedule for either lumpectomy or mastectomy. I do both of those. Lumpectomy is defined as removal of a lump with a rim of normal tissue around it. Patients that receive lumpectomy for treatment of breast cancer ultimately will require radiation therapy as well for treatment of the rest of the breast. And then the alternative to lumpectomy with radiation therapy is mastectomy. Mastectomy is obviously non-breast conserving surgery. That's removal of the breast. And actually, I wasn't late today, thankfully, but I had a double mastectomy, bilateral mastectomy that I did on a patient this morning. So. Might need help with sorry. I don't know if I bumped it or hit it.
Oh, I see. Okay.
I would just erase there. Okay.
Yeah.
And then advance. Perfect. So endocrine surgery, endocrine is hormone glands essentially, and the two ones that I primarily deal with are the thyroid and the parathyroid. Both of those are in the neck. Thyroid gland is kind of what we call the master endocrine gland. It secretes a hormone that upregulates metabolism of the body. You can have all sorts of diseases of the thyroid gland. You can also have nodules that grow in the thyroid gland. And from a surgical standpoint, the primary therapy is to rule out malignancy when you're talking about the thyroid gland. We do that with what's called a fine needle aspiration biopsy. That's something I do in the office. It's done with the use of an ultrasound. It's basically removing small cells from the thyroid gland, sending that tissue off to the pathologist to let them look at it underneath the microscope, and they will give us a diagnosis indicating what we're dealing with. If it does turn out to be cancer, then ultimately a lot of times we'll schedule patients for either a unilateral one side of the thyroid gland or a complete thyroidectomy. And that's the best treatment for somebody with thyroid cancer. Parathyroid glands, typically patients have anywhere from 3 to 5 of those. They're much smaller. They're about the size of a small marble. They're located either right next to or within the thyroid gland occasionally. Parathyroid hormone that's produced by the parathyroid glands is what controls calcium metabolism. So if you have what's called hyperparathyroidism, too much parathyroid hormone, your calcium levels can go sky high. And parathyroid hormone causes calcium to come into the body through the gut. It also causes breakdown of bones. And so if you have like a parathyroid tumor that's producing too much parathyroid hormone, bones can become brittle and you can have breaks. And oftentimes if you have a single gland that's producing too much parathyroid hormone, that gland needs to be removed. That's something that we can do here in the operating room. Foregland disease is another possible problem that can lead to hyperparathyroidism. If you have foregland disease, oftentimes you need 3.5 glands removed. And that's something that just based on the fact that if you're removing all the glands and you'd like to keep one gland left behind to still produce some parathyroid hormone, oftentimes that gland is auto-transplanted into the muscle in the forearm. That's not a procedure that I do here, but ultimately we could get you sit down to make it if you had hyperparathyroidism secondary to multiple gland disease. So the digestive system starts at the mouth, ends at the anal opening. Obviously, you have the esophagus, stomach, small intestine, large intestine. Other organs that contribute to the digestive system include the liver, the gallbladder, the pancreas. All of those can have surgical issues, and I deal with pretty much all of them. Predominantly what we see here, probably the most frequent surgery that I do is gallbladder surgery. Patients get that, and it can lead to abdominal pain, typically in the upper quadrant, nausea, vomiting. That's a procedure that we do laparoscopically if patients need their gallbladder removed. We can also do open gallbladder surgery, sort of the old-fashioned way of doing it. We prefer not to, and patients prefer us not to do that because it means that they end up staying in the hospital for a few days and it takes longer to recover from. But occasionally that's required from the standpoint of just getting an operation done safely. So all those organs, you can obviously have individual diseases of the stomach, small intestine, large intestine, malignancy or cancer of any of those organ systems. I'll touch base on this a little bit later, but basically when we're talking about doing gut surgery, there's what's laparoscopic and open gut surgery or open abdominal cases. Where I trained in Atlanta, we were always taught to think laparoscopically first, so minimally invasive surgery. That involves putting small tubes or incisions into the abdominal cavity that we can then put instruments through. One of those instruments is a camera so that we can see what we're doing on the inside. And pretty much if I'm ever faced with a abdominal issue, that's the way I think. If I can do this laparoscopically, that's what I do because I think it's advantageous for the patient to get it done that way. If for whatever reason, there's a number of reasons that you can't always accomplish it safely laparoscopically, we can certainly convert to open. Any questions thus far? Colorectal care. So colorectal is one of those subspecialties of surgery. Once you finish your 5 years of residency, you can actually, you have a choice of multiple different things that you can subspecialize in. If you've heard of a colorectal surgeon, that's somebody who normally would have done 5 years of residency and then either 2 to 3 years of fellowship just for colorectal care. You're trained in some colorectal care just with general surgery. So you see it, you do rotations on it, you get trained in it. Some of the more advanced stuff we wouldn't do here, and I haven't done, but certainly basic stuff. Treatment of hemorrhoids, anal fissures, anal fistulas, and in some treatment of both Crohn's disease and ulcerative colitis. The simple stuff I still do a fair bit of. If it involves taking patients to the OR, those are normally pretty quick, painless outpatient cases. And patients do very well with that. If it's more involved, colorectal care, low-lying rectal cancers, complicated ulcerative colitis or Crohn's disease, that's something that we would send down to make into the colorectal surgeons and the gastroenterologists down there. Hernia surgery, do a ton of hernia surgery. There's all kinds of hernias. A hernia is defined as basically a hole in the muscular layer that allows things to penetrate or bulge out through it. You can have diaphragmatic hernias, which is the diaphragm is the muscle between the chest cavity and the abdominal cavity. Or you can have ventral hernias that are on the anterior abdominal wall, including the belly button, which is called an umbilical hernia, and then also inguinal hernias in the groin. I fix those both laparoscopically or open, depending on what I think is the best for the patient. Normally, the hernias that I fix are outpatient hernias. They aren't huge hernias that require long hospitalizations. If they're pretty complicated, big surgeries, that's something that we would send to Macon. But for smaller, more outpatient type hernias, we fix those all the time here in Milledgeville. Oncologic surgical care. Oncologic is cancer care. We've kind of already touched base on that, but you can develop cancers of the soft tissue and we can resect those and treat those. We do have oncologists in town to help us with treatment from a chemotherapy or hormonal therapy standpoint. We also have radiation oncology if something requires radiation. So we've really got a full sort of assault team that can handle most cancers or a lot of cancers. Cancers of the GI tract, like we talked about, stomach, small intestine, large intestine, all those we do. Cancers of the breast, like I said, I did a double mastectomy on a patient this morning for treatment of her breast cancer. Cancers of the thyroid gland. It's rare that patients would develop parathyroid gland cancer, although it's possible that you can see it. And then the other sort of procedure that I do for patients that have cancer and require chemotherapy is put a port in. A port is basically a implantable long-term IV that we use for access to a patient's venous system. It acts as an IV long-term, but there's a portion of that port that's underneath the skin, typically up in the chest, that we can access with a small needle. And it gives us instant access to a patient's bloodstream rather than having to search for a vein in their arm that we can put an IV in. For patients who are requiring long-term chemotherapy, to re-access over and over and over again their arm, a vein in their arm, it becomes very difficult, very painful. It's frustrating for both the nurses and the patients. And ports are kind of a God saver from the standpoint of making patients' lives better and easier. even though you have to go through a minor procedure to have one put in, it's a dependable long-term IV access that we can use for patients. Vascular surgery care includes ports, dialysis catheters, so patients that have end-stage renal disease or acute kidney failure that require hemodialysis. We put in special types of long-term IVs that patients can get dialysis through. That's all something that we do here, and patients can stay in town and have their dialysis here as well. The last thing that you see there, IVC filter placement, is almost like a cage that we put in the inferior vena cava. The inferior vena cava is the main vein that drains the lower half of the body into the heart. You have an inferior vena cava and a superior vena cava. For patients that have lower extremity blood clots, DVTs, deep vein thrombosis in their legs, and are not good candidates for long-term anticoagulation, which is how we normally treat those, we'll put a filter in, and the idea is to prevent an event where a blood clot can break loose from the lower extremity veins, travel up through the inferior vena cava, go into the heart, go into the right side of the heart, and then ultimately get passed into the lungs. That's where you call it a pulmonary embolus. Pulmonary emboli, if they're large enough, it's a fatal event. Patients can drop dead just like that from having a massive pulmonary embolus. And the idea behind the IVC filter is to basically put a cage in the inferior vena cava that has small holes. It's almost like a fence or a screen that allows blood to travel through it, but it will catch a clot, and certainly a big clot. So if the clot is caught prior to it getting into the lungs and causing a massive pulmonary embolus, the clot will eventually absorb, if you will, in the inferior vena cava on its own. And if we prevent it from going into the lungs, you're going to prevent that fatal event. So that's something that we do for patients that are not good anticoagulation candidates that have a lower extremity DVT. This just basically talks about what I spoke about earlier. Where I trained, we were always Atlanta Medical Center. What was Georgia Baptist was the very first hospital in the state of Georgia to perform laparoscopic gallbladder removal. It's something that now takes about 30 to 45 minutes to do. The first case was done before I ever got there. It took over 5 hours to do that case laparoscopically. We've advanced significantly from the standpoint of doing pretty simple cases like laparoscopic cholecystectomy to now doing things like laparoscopic colon cancer removals. So all of that stuff I was trained on, and I was taught to think that way first, and that's what I do. We can certainly still do cases open, but like we talked about before, it's to the patient's benefit to get them out of the hospital and they recover faster if we're able to do things laparoscopically. The last slide, I think, is just a thank you slide. I want to thank you guys again for letting me be here and present this stuff to you. And then contact information is on the bottom. I know Kirsty put out sort of flyers and cards. I accept all patients. I see pretty much everybody. There's no insurance issues or anything like that. So if you guys have known problems or family, friends that have general surgery problems. Oh, but before no, so I'll be happy to see anybody. And if it's something that we can't handle here, my wife always says sort of my best attribute from the standpoint of what she knows about me in the operating room and doing surgery is that I know what I can and what I can't do. And I'm pretty vigilant about not taking care of patients where I don't think this is the right place for them. So, but if I can do it, like I said, we don't do everything in Milledgeville. We talked about this before. There's certain specialties that we don't have, certain facilities that we don't have. We don't have everything that Macon has. We certainly don't have everything that Atlanta has. But what we do here, I think we do very well. And I'm a small part of that, but we'll certainly be happy to see patients if they want to, have things done here in Milledgeville from a general surgery standpoint.
Questions for you too.
Yeah. Shoot.
Yes,
Yeah, absolutely.
Hey, just got.
That's what I heard. Who are you talking to?
Christopher, Dr. Ryan, when I heard you say, don't call me Christopher, I thought, okay, Seth. Dr. Ryan, Dr. Ryan, I got a question for you.
Yep.
First of all, thank you for coming in. and sharing
Absolutely.
your expertise and a little bit about your profession. That's a big part of what we do here at Rotary. I have a question, it's pertaining to one of our 7 focus areas of Rotary, which is disease prevention.
Okay.
And I'd like to know, based on what you've seen as far as the patients and the cases you dealt with, what are you seeing that is coming into the operating room or becoming fatal? And you know that there's clear technology, there's clear early detection systems out there to pick this stuff up earlier. So not to take you out of the job, Dr. Ryan, so that it doesn't lead to the operating room or it doesn't lead to mortality.
Yeah. So from the standpoint of, I think pretty much everybody in this room is close to or nearly as old as I am. Not quite everybody, but from a screening standpoint, the things that certainly need to be done, and everybody's heard about this and you all know it, but from a female standpoint, obviously mammograms, that's the biggest thing. That's the number one leading cause of cancer death in women. And mammograms is the best detection that we have. Mammograms were started to essentially find lesions before they can be felt. And we know from treating breast cancer patients that the larger a tumor is, the more advanced it is, the more deadly it is. Okay. So mammograms are meant to see lesions in the breast before they can be felt. For a patient without family history of breast cancer, mammograms need to start at age 40 and every year thereafter. For patients that do have a family history of breast cancer, this varies, but most docs would recommend taking that back to 35. The problem with some people will ask, well, why don't we do mammograms starting at 20? And the reason for that is that women who are in childbearing years, their breasts are much denser than older breasts. So as you age, the breast becomes more fatty, if you will. Mammogram, the x-ray used in mammogram can penetrate the breast better, and we get much better quality pictures by doing mammograms on older patients that have fatty replacement of their breasts. If we do mammograms on younger patients, which we still occasionally do, the film quality is not nearly as good. It's much harder to pick up disease. But certainly, at least from a surgery standpoint, mammograms is the number one thing that women can do. For men, obviously prostate cancer is the big thing that we talk about in terms of screening. And although I don't do this, Dr. V, one of the urologists, does this all the time. Palpating prostates and obviously sending off PSAs. Prostate specific antigen is a blood test that we can get for patients to determine if that's high, then patients would have an increased risk of developing or having prostate cancer, and that can certainly lead to early diagnosis and treatment. And then the last thing I think that's real important, that's sort of along with my field, is colonoscopy. Colonoscopy basically is colonoscopy and endoscopy. Endoscopy isn't something that we necessarily do as a screening test, but when patients have either reflux symptoms, nausea, if they have lots of vomiting, then the upper endoscopy can be done. That's more of a diagnostic study. It's not a screening study. But colonoscopy is a screening study, and basically that involves cleaning out the colon, taking a prep, if you will, prior to the study, and then seeing a gastroenterologist who does that. That's an outpatient procedure. You come in, you have it done. It takes 20 minutes. If there's polyps or things inside the colon that can be biopsied, that would be done at that time. And colon cancer is another big cause of death in patients, and so. Those three things are sort of the big things when it comes to screening.
Thank you. On the colonoscopy, when is the recommendation of having the first one, and how often after that?
Yeah, it's so I don't do those, and I can't. The recommendation changes all the time, but generally speaking, I think. It used to be 50 for your first colonoscopy, and they moved it recently back to 40. So you can now get a screening colonoscopy starting at 40, and then depending on what's found at that colonoscopy will determine how often they recommend it thereafter. I had one when I was 50 because it was still, I'm 51 now, but ultimately didn't know that they had changed it to 40. And so I had it when I was 50. Barb and I had ours together. Not in the same room, but at the same day. So we made a trip down to Macon because I didn't want anybody looking at me that way here. But anyway, we had our colonoscopies. I had a polyp, a small polyp that was removed. It was benign, and ultimately they said, well, we need to do it again in 5 years. So normally it's 10 years if you have a clean colonoscopy. If they find benign polyps or if they find other things that put you at risk, they'll tell you to come back sooner, if you will.
I would have thought you would have said, as far as preventive stuff like the gallbladder, there seems to be a lot of gallbladder surgery.
Yep.
In the South. I don't know, is that all related to a lot of
Diet.
fried chicken?
Yeah.
So,
Yeah, so patients can develop all kinds of gallbladder problems. The gallbladder cannot function well. You can develop stones. I've never had a gallbladder attack, but there's lots of people in this room. I've operated on some that have had it. And if you ask those people, they'll tell you it's the worst, one of the worst pains they've ever had. Women compared to having a child before they get an epidural. So it's not a fun thing. There's not really a great screening test, but there are preventative things. If you're having symptoms, we always tell patients to avoid fatty, fried, spicy, and greasy foods. The gallbladder is asked to work when we eat. It squeezes and it's asked to inject or secrete bile when we eat. And so, especially when patients eat fatty or fried foods, that's when the gallbladder starts working. If you got a problem there, that's what's gonna kick that problem off. So if you're having rapid quadrilateral pain, nausea, vomiting, pain that radiates through your back after eating, that's a gallbladder problem most likely. And although there's not really a preventative thing that we do, I would tell patients to try to avoid those types of foods if they're having those symptoms. Yep.
But two things, how many general surgeons are there in those?
When I went to, yeah, just myself and Briar at this point. When I came, there were 4.
Okay, yeah.
And Mike Roberts, who I know was a member of this club at one time. He retired from general surgery practice probably 8-9 years ago, I guess. And then Dr. Langston, who was my partner before he left, before Navicent was bought by Atrium, he was the other. So we had 4, but now there's 2.
And the same thing, how are you in surgery typically on every day, 3 days a week? I mean, what's a normal week if there is?
So because there's 2 general surgeons in town, one of us is on call 20 around the clock. So we pretty much are on every other day, every other weekend call. So there's somebody always on call. And my schedule is such that I see patients typically in the office on Monday, Wednesday, and Friday, Monday, Wednesday all day, and then Friday mornings. And I schedule elective cases on Tuesday and Thursday. Now that's quite variable. Sometimes I've got emergency cases that I've got to do if I'm on call. Sometimes I schedule on cases on my operative days, but generally speaking, that's the schedule I try to stick to.
Right.
Anybody else? Yeah.
For those who have deep vein
Thrombosis.
thrombosis, are there screenings for those, or is there a type person that's prone to that? How does
Yeah,
that
so-
come to be? Because I hear about that and I don't think.
I'm probably not another good example of this, but 10 years ago now, I was out on the golf course here playing golf. I squatted down over a putt, my back went out. And for 3 months, I was debilitated from having herniated discs in my back that ultimately I needed to have surgery for. For those 3 months, I was still working, but not as much as I am now, obviously. And I was immobile from the standpoint of I just couldn't move very well. It was horrific. I was scheduled for surgery on a Monday. This was 3 months after going through all the treatments. And on the Sunday night before surgery, I looked at my left leg and it was twice the size of my right leg. And so you hear about people who are immobile, who are stuck on an airplane or a car ride for a long time. People who the main thing that prevents blood clots from forming in your legs is preventing stagnancy, I guess. And so when you get up and move, the muscles in your legs squeeze the veins, that causes the blood to go back towards the heart. It keeps the blood moving, if you will. If you're not moving and you're sitting down for long periods of time, or if you're stuck on a plane, that can cause blood to become stagnant and stagnant blood clots, okay? And so although there's not a screening thing to do, the answer to your question is move. I wasn't moving, and ultimately I was also diagnosed with a blood clotting disorder, so I'm more prone to forming blood clots. And that's why my DVT occurred, and thankfully I'm not a contraindication of being anticoagulated, so I'm chronically anticoagulated secondary to the fact that I had a DVT, and I also have this blood clotting problem, if you will. But the answer to your question is there's not a screening thing that we do. If somebody comes in with a swollen leg, we'll get an ultrasound to diagnose it. But what patients can do to try to prevent that is just get up and move. Okay. Sleep, like if you're sleeping at night, you're moving enough, and if you're getting up and out of bed the next day, you're not going to develop a routine DVT. But if you're stuck on a plane without moving for a long period of time, if you're stuck in a car for a long period of time, those patients are at risk. Thank you guys so much. Appreciate it.
And Dr. Ryan, we have a program called Jill's Books where we donate books to the local library, and we have our speakers sign them. So if you wouldn't mind, sign this, all the beaten apart. And these are handmade wooden pins by Brady Blake. You get to take one and keep it. See, Greg can tell you what kind of wood it is.
Let's see. How about that?
I'm forward to you.
Right, and I have just a couple of things that we forgot to announce. We have a new member who, no, not a new member, but she is at her second meeting. And so we did not put her name on the table, but I'm gonna throw it out there so that she can get inducted. Lily Anna, is she here?
Really had one final today.
Okay,
Post graduation, but she's super excited.
okay, and how do you pronounce her last name? Lily Anna Kovacheva. She works at Responsive Technology with Tamara and Tom. And then next week, who is our guest speaker?
It is Wesley Nunn with Georgia Narcotics Officers Association.
Okay, and I will not be here next week. I'll be on vacation. Woo-hoo for me. Jennifer is gonna lead the meeting next week for us. No, not letting her go. We're not letting her go. There is a Rotary Leadership Institute this Saturday. I don't think it's too late to sign up if you're interested in getting training. And if y'all will bear with me 1 second, I want to make sure everybody knows who our board is so that they know who to turn to for help. If you need it, Wendell is our president-elect. I think everybody knows that Fred is on service projects. Tamara is in charge of our speakers. Kristen has taken the membership role. Lynn Chandler for foundation. Jan Hordan for interact for our club. Past president is Jennifer Pollard. And member at large, Halsey Levitt has joined our board as member at large. And then we're excited about this, our sergeant at arms, Greg Blakely. You need anything, grab any of us. Oh, I forgot my treasurer. Oh my gosh, Dawn. And Eric for secretary. It's a larger board than we've ever had. Michelle for public image. Yes, it's a. Thank y'all. It's a larger board than we've ever had, but we got great people doing the right things. So, and I would like to continue Jennifer's tradition of having a positive statement at the end of every meeting. I don't know who to attribute this to. I found it on the Rotary website. The best way to find yourself is to lose yourself in the service of others. And with that, I'm gonna adjourn the meeting. I was looking going, who am I?
Okay.